Imagine you are at the gym right now.
Okay.
You're lacing up your shoes, uh, getting ready for a workout. You look over at the woman on the treadmill to your left, sprinting through these intense intervals.
Right.
And then you look at the woman to your right, chalking up her hands, getting ready to pull a heavy deadlift.
Yeah, standard gym scene.
Right. But statistically speaking, one of the three of you is dealing with a biomechanical failure. So incredibly common, yet so silent. Nobody ever talks about it.
Wow.
That is, until they leap and they leak.
Yeah, it's such a hidden issue.
Exactly. We're talking about an internal structural bridge collapsing under sudden pressure, and it affects nearly half of all women who participate in high-impact exercise.
It really is the absolute definition of a silent failure. I mean, we condition ourselves to look for the visible cracks in the athletic concrete, right?
Like what?
Like a pulled hamstring or, a snapped ligament, a swollen knee.
Like things you can see.
Exactly. And we can easily tape those up or brace them. But when the pelvic floor gives way during a heavy lift or a box jump, it's treated like a personal failing. Or just, the unavoidable cost of getting older or having kids.
Which is just, it's so frustrating. And our mission today is to completely dismantle that misconception.
Absolutely.
We are going to explore the mechanics of stress urinary incontinence, or SUI, specifically during physical exercise.
Yeah.
And more importantly, how specialized internal vaginal devices, ranging from standard menstrual tampons to highly engineered over-the-counter inserts, mechanically solve this problem.
By basically acting as instant, non-surgical scaffolding.
Exactly. And to do this, we've pulled a really fantastic stack of sources to analyze for you today in this deep dive.
We really have. I mean, we are synthesizing data from clinical trials on product efficacy, looking really closely at devices like Uresta and Poison Pressa.
And regular tampons too, right?
Yeah, exactly. Regular tampons as well. But to really get to the bottom of how these work, we're also digging deeply into complex biomechanical modeling studies and anatomical reviews.
Because you have to understand the physics of the human body in motion.
You really do.
Actually, if you look at our backdrop right now, we've transitioned to a dynamic 3D anatomical model of the human pelvis.
It looks so cool.
It does. And overlaid on top of the muscle and bone are these glowing blueprints of structural engineering. So you see like load-bearing struts, tension cables, pressure valves.
Because truly, biology and biomechanics are they're completely inseparable here. You cannot understand the leak without understanding the load.
Right.
So we need to start by looking at the architecture of that leak.
Okay, let's unpack this, because it isn't just a random glitch where the bladder decides to give out, right?
No, not at all. Before we can analyze how a silicone device or a tampon actually fixes the problem, we first have to understand the mechanical failure that causes the leak in the first place.
So it's a very specific battle of physics happening inside the abdomen.
What's fascinating here is the simple math of continence.
Math?
Yeah, I mean, it all comes down to a dynamic equation of fluid pressures. On one side of the equation, you have your urethral closure pressure.
Okay.
Think of this as the physical force pinching your urethra shut.
Right, the pinch.
Exactly. And then on the other side, you have intra-abdominal pressure, or IAP. That is the heavy downward force pushing on your bladder from above.
Okay, I'm following.
So as long as your closure pressure, the pinch, is higher than the intra-abdominal pressure pushing down, you stay dry.
That makes perfect sense from like a fluid dynamics perspective.
Yeah.
If the pressure holding the door shut is stronger than the water pushing against it, nothing gets through the door.
Exactly. The problem seems to arise when that intra-abdominal pressure suddenly spikes.
Like when you laugh.
Yeah, laughing heavily or coughing, which medical literature refers to as the Valsalva maneuver, or, going back to our gym scenario, pulling a 200-pound barbell off the floor.
Wow. Okay, so what actually happens inside when you do that?
Well, those actions cause a massive sudden pneumatic wave inside the abdominal cavity. Your diaphragm pushes down, your abdominal muscles pull in.
And all that displaced pressure has to go somewhere.
Exactly. It goes straight down into the pelvic floor. And this is where we have to look at the anatomy through the lens of Delancey's hammock hypothesis.
The hammock hypothesis.
Yeah. So for a long time, the clinical assumption was that the pelvic floor was just like a generic, solid block of muscle that you squeezed.
Just one big muscle.
Right. But Delancey's work proved it is actually a highly complex fibromuscular hammock.
Okay, wait. I want to pause and translate some of the medical terminology from those anatomical reviews we read, because the distinction really matters for the listener.
Go for it.
The literature talks about the endopelvic fascia
Mm-hmm.
and the anterior vaginal wall. So for anyone trying to visualize this, think of the fascia like the tough, fibrous casing around a sausage.
That's a great visual.
Right. It is a muscle. It's structural connective tissue that provides tension and integrity.
Mm-hmm.
And then the vaginal wall is the flexible, responsive tissue that the fascia supports.
Right.
So together, they create this trampoline-like hammock right under the urethra.
Yes, and when your intra-abdominal pressure rises, like from a cough or a jump, a healthy anatomically sound system actually uses that very downward pressure to its advantage.
Wait, really? It uses the pressure?
Yeah. The pressure wave pushes the urethra down, but it compresses it firmly against that taut fibromuscular hammock. The hammock acts as a rigid backstop, smashing the tube closed.
Oh, I get it. So it is essentially like stepping on a garden hose to stop the flow of water.
Exactly like that.
So if the ground underneath that hose is solid concrete, which I guess represents a strong, healthy fascial layer and pelvic floor, stepping on the hose stops the water instantly.
Because the concrete provides the firm backstop.
Right. It doesn't yield, so the hose gets pinched shut.
That is the perfect visualization of a continent pelvis.
Hmm.
But let's look at the biomechanical failure now. Imagine the ground underneath the hose is no longer concrete. It is soft mud.
Oh, boy.
Yeah.
Yeah.
This represents a weakened supportive fascial layer, which can happen due to the sheer mechanical trauma of childbirth.
Sure.
Hormonal changes from aging, or just, a genetic predisposition to softer connective tissue.
So stepping on the hose in soft mud doesn't pinch it shut at all. It just pushes the hose deeper into the mud.
Yep.
It sinks, it deforms the ground around it, and the water keeps right on flowing because you never actually flatten the tube.
Exactly. When that fibromuscular hammock is lax, the urethra loses its concrete backstop. When the heavy pressure spikes from a box jump, instead of being pinched closed, the urethra descends.
These are mud.
Right? It gets pushed downward into the pelvic cavity and forms a funnel shape. The anatomical studies we reviewed, like the work by Pelsang and colleagues, demonstrate that this funneling actually shortens the functional length of the urethra.
And in fluid mechanics, a shorter tube inherently provides less fluid resistance.
Exactly. The pressure drops, the resistance drops, and the seal is broken.
The ground is too soft, and the hose sinks. So if the core issue for you, our active listener, is that the ground under the urethra has essentially turned to mud, how can you quickly reinforce it?
Without going to surgery.
Right. So you can hit the gym today without going under the knife for invasive sling surgery.
Well, that question leads us to this massive grassroots movement where women started using traditional menstrual products in highly non-traditional ways just to survive a workout.
The famous tampon hack.
Yes. Women have been using standard menstrual tampons for decades to try and stop exercise-induced leaks. It is a completely patient-driven solution that became so prevalent it finally forced the medical community to conduct actual clinical investigations.
Wait, I need to pause here. Because when I was first reading the notes on the tampon hack, my immediate thought was just absorption?
Oh, sure. Most people think that.
Yeah. I assumed that women were putting in a tampon before a run, and the cotton was basically acting like a sponge or a plug to soak up the urine as it leaked out.
Right.
But the ultrasound data we have says something completely different.
It really does. It is incredibly common to assume it is acting as a sponge, but the mechanical reality is entirely different. It is absolutely not about absorption.
Okay, so what is it doing?
The tampon is acting as a structural prop. Going back to your mud analogy, the tampon acts as an internal brace placed inside the vagina. Because the vaginal wall sits directly beneath the urethra, introducing a firm object into that space provides the physical stiffness, the concrete backstop, that the suburethral layer is missing.
So it physically pushes upward, creating tension so the urethra can be pressed closed from behind.
Exactly.
That is wild. It isn't catching the leak. It is providing the missing structural scaffolding to prevent the leak from happening in the first place.
Exactly.
And we aren't just guessing this based on like pad weights or subjective surveys. We have live imaging proving the physics.
Yeah, a brilliant study by Tan and Sherburne out of the University of Melbourne provides the definitive proof on this.
What do they do?
They took women who routinely experienced stress incontinence and utilized transperineal ultrasound.
Okay, so imaging from the outside.
Right. This means they were conducting live imaging of the pelvic organs from the outside, watching the internal architecture move dynamically while the women were actively coughing and doing jumping tests.
Wow.
And they tested them first with an empty vagina and then with a regular tampon inserted.
Watching that on an ultrasound
Mm-hmm.
means they can physically see the hose sinking into the mud in real time,
Yeah.
and then see what happens when you slide a piece of concrete under it.
Yep. And what the imaging revealed was a significant reduction in a measurement called the gamma angle when the tampon was in place.
The gamma angle.
Right, it measures the posterior rotational descent of the bladder neck.
Okay.
So when you jump, the bladder neck wants to rotate and drop backward, opening that funnel we talked about earlier.
But with the tampon.
The tampon physically occupied the space behind it, stopped the bladder neck from dropping, and held the urethra firmly against the pressure wave.
But, reading further into that Melbourne study, there's a massive caveat.
Yeah, the acceptability part.
Right. They noted a very specific acceptability statistic. Only 47.1% of the participants found using a regular tampon to be a highly acceptable form of management for their leaks.
Less than half.
Less than half. So it works mechanically, it provides the backstop, but the user experience is clearly failing the athlete.
It becomes obvious when you look at the material science of a tampon. I mean, menstrual tampons are explicitly designed to absorb moisture and expand.
Right, that's their whole job.
Exactly. So if you are using one on a random Tuesday when you don't have your period, just because you want to go for a run, that highly absorbent cotton is going to wick away all the natural, necessary vaginal moisture.
Ouch.
Yeah, that causes intense friction, microscopic tearing, drying, and significant discomfort. They act as a fantastic proof of concept in a pinch, but they are not engineered for this specific biomechanical job.
So if a regular tampon feels like sandpaper because it's absorbing moisture it shouldn't be, how do you create a shape that holds the urethra up without acting like a sponge?
Well, that is where the medical engineer stepped in, leading to the rise of purpose-built, over-the-counter urethral supports.
Okay.
If we connect this to the bigger picture, the evolution of these purpose-built devices is all about providing that crucial non-obstructive support to the hammock while entirely removing the absorbent, drawing effects of a menstrual sponge.
Makes sense.
We are moving from a makeshift, grassroots hack to precision medical engineering designed specifically for active living.
Here's where it gets really interesting for the listener, because these aren't devices you need to schedule a surgery for, or even necessarily see a specialist to obtain.
Nope.
These are off-the-shelf solutions empowering women to take control of their own biomechanics. Let's look at the specific designs because they tackle the geometry differently.
Let's do it.
Uresta is a standout in the clinical data.
Uresta is a fascinating approach to the geometry of the pelvic floor. It is a reusable, bell-shaped device made of medical-grade plastic. You self-fit it, inserting it into the vagina where the wide, firm base of the bell sits right behind the pubic bone. It gently presses upward and outward, applying targeted support directly against the urethra.
And no sponge effect.
Exactly. It doesn't absorb a drop of moisture, it just provides architectural tension.
The long-term data on Uresta is what really caught my eye. We reviewed a 12-month follow-up study on compliance, which is usually where medical devices fail, right? People just stop using them.
Yeah, device fatigue is a huge issue.
But 90% of the Uresta users were still using it after a full year. That is a massive retention rate.
It really is.
Furthermore, 83% reported significant improvement in their stress incontinence during their daily activities.
It speaks volumes about the comfort and the true mechanical efficacy. And the scientific community is deeply invested in mapping exactly how much better these purpose-built devices perform compared to the old hacks.
Right.
There is currently an active clinical trial running that is comparing the Uresta device directly against Sportech's regular tampons, specifically tracking running and high-impact sports.
But maybe you don't want a reusable plastic bell. Maybe you want something that feels familiar. Which brings us to another category. Disposable, over-the-counter devices like Poise Impressa.
Or similar international designs like TampSec and Control.
Right. When I first looked at the Impressa device, it looks virtually identical to a tampon. It even comes in a smooth plastic applicator. But the internal engineering is entirely different.
To the naked eye, the deployment mechanism is exactly the same, but the materials are radically altered. Inside that familiar applicator shape is a medical-grade silicone core.
Not cotton.
Not cotton. That core is surrounded by a soft polypropylene covering that is entirely non-absorbent. When you push the plunger on the applicator, it doesn't leave a cotton plug behind.
What does it leave?
It deploys the silicone core, which expands to create a soft, flexible diamond or anchor shape.
So it opens up to span the width of the vaginal canal, creating a tension bridge.
Exactly. That flexible diamond shape provides lateral tension across the vaginal wall. It acts like a shock absorber, supporting the urethra from below during a heavy impact.
And without drawing out any moisture.
Right, without creating the friction that ruined the tampon hack for 50% of women.
The clinical efficacy numbers for Impressa are incredibly robust. In a 28-day study, 85% of the women using it achieved a greater than 70% reduction in their leakage volume based on clinical pad weights.
Huge numbers.
But more importantly for your quality of life, 92% reported feeling dry and confident during strenuous high-impact activity.
And they utilize a very clever sizing kit system. Women buy an over-the-counter kit that comes with sizes 1, 2, and 3.
So you don't even need to be measured by a doctor.
Exactly. You start with the smallest size. If you put it in and still leak during a jump rope session, you simply step up to size 2 and then size 3 until you find the perfect custom mechanical fit for your specific pelvic geometry.
All without a doctor's prescription.
Oh, yeah.
It is essentially like going to a specialty running store and buying an orthotic insert for your shoe. If you have a fallen arch, you don't stop running forever. You buy an arch support that provides the structural stiffness your foot is missing.
That's a great way to look at it.
These devices are literally orthotics for your pelvis. They let an athlete instantly get back to running, jumping, or lifting heavy weights safely.
This raises an important question, though, regarding the intersection of passive devices and active biology.
What do you mean?
Well, we have a structural mechanical fix you can buy off the shelf, but how does popping in a silicone insert play into long-term athletic performance and overall pelvic floor health?
Right.
Does using an internal brace mean you can just ignore the underlying muscle weakness forever?
The classic crutch debate. Does wearing a knee brace mean you shouldn't do physical therapy for the knee ligaments?
Exactly the opposite. The research strongly suggests we need a nuanced understanding of real-world athletic impact versus clinical testing.
Okay, let's get into that.
For decades, the gold standard in a urogynecology clinic for testing incontinence has been asking a patient to lie on an exam table and cough.
Just a cough.
Yeah. That Valsalva maneuver creates a very specific, relatively mild type of downward pressure.
But the women we talked about at the top of the deep dive aren't just lying down and coughing. They are landing from 3-foot box jumps. They are pulling hundreds of pounds off the floor.
And our sources highlight a groundbreaking computational modeling study by Dias and colleagues that proves just how different those environments are.
What did Dias do?
They built a computer model to simulate the exact forces of a jump landing process on the pelvic floor.
Oh, wow.
Yeah, and what they found was that the pelvic floor deformations generated when your feet slam into the ground during a jump landing are vastly different in terms of shear stress, directional force, and timing than those caused by a simple cough.
I mean, the physiological forces must be exponentially more violent and complex. The pelvic floor is catching the entire weight of your internal organs multiplied by gravity and momentum.
In high-impact sports, the intra-abdominal pressure generated is staggering. Take young female powerlifters, for example.
Yeah.
One comprehensive study noted that 50% of them report urinary incontinence. Half. Let that sink in. Half of the strongest young women in the gym are dealing with structural leaks.
That is incredible.
So for these athletes, a device like Uresta or Impressa isn't a crutch. It might be an absolute mechanical necessity to survive the sheer physics of the lift without blowing through the sphincter's closure pressure.
But the literature emphasizes that the device is just the passive brace.
Right.
It provides the concrete backstop, but it shouldn't be your only strategy.
No, absolutely not.
You still need active muscle engagement.
The passive structural support must be paired with active pelvic floor muscle training, or PFMT. You have to rehabilitate the tissue.
Right, like Kegels and biofeedback.
Exactly. And the most critical component of that training for an athlete is mastering something called the knack.
I found the mechanics of the knack deeply fascinating because it is all about neuromuscular timing.
Yes, timing is everything.
It is defined as a voluntary, conscious pre-contraction of the pelvic floor muscles right before a stressful event. But why is that pre-part so critical? Why can't you just squeeze really hard when you feel the impact?
Because if you wait until you feel the impact, you have already lost the physics battle.
Too late.
Exactly. Think about the jump landing. The pressure wave travels downward the microsecond your feet hit the floor. If the neuromuscular signal to contract the muscle fires after your foot hits the jump box, that pneumatic pressure wave has already blown past the sphincter.
It's just too fast.
Right. So biofeedback and PFMT train your brain to brace the concrete before the hose is stepped on. You intentionally squeeze and lift the pelvic floor a split second before you land, or right as you brace your core to unrack the barbell.
So if we synthesize all of this data, the ultimate strategy for an active listener dealing with SUI is a comprehensive dual-layer approach.
A dual-layer approach, exactly.
First, you use a device like Uresta or Impressa for immediate passive confidence. It gives you the internal concrete backstop so you can live a leak-proof life today without giving up the sports you love.
Right. Keep doing what you love.
And second, you pair that device with biofeedback and PFMT to actually rehabilitate the muscle tissue and train your nervous system for that pre-contraction knack. The device lets you safely stay in the gym while you do the hard work to heal.
It is the perfect synergy of passive engineering meeting active biology. You are providing an immediate mechanical solution while building long-term physiological resilience.
To wrap up our deep dive today, we really want to reiterate that experiencing SUI during exercise is a structural mechanics issue.
Yep.
It is a matter of fluid dynamics, tissue tension, and sheer physical force. It is not a personal failing, and it is absolutely not something you just have to accept as your new normal.
Definitely not.
Whether you are utilizing a standard tampon in a pinch at the gym or investing in a highly engineered silicone insert like Impressa or Uresta, you now have incredibly effective non-surgical options to act as that critical internal scaffolding.
It is entirely about having the right tools to manage the intense physical forces your body is subjected to when you push its limits.
So what does this all mean for the future? Where's the sports science heading next for athletic women?
I think we have to look back at the implications of that computational modeling study by Dias.
The jump landing one.
Right. Right now, current clinical diagnostics for SUI primarily rely on a patient lying perfectly still on an exam table and coughing.
Yeah.
But since our sources definitively prove that a dynamic jump landing creates entirely different, far more complex pelvic deformations, it suggests that the entire medical field's diagnostic standard might actually be fundamentally flawed when it comes to active women.
That is a massive paradigm shift. If you're only testing a static cough, you are completely missing the biomechanics of the athlete in motion.
It is a critical blind spot in urogynecology. The human body in motion requires dynamic medicine.
And that is the thought we want to leave you with today. As we learn more about the intense physics and biomechanics of sports, will the urogynecology clinic of the future need to physically change its layout?
They might have to.
Will they have to replace the static exam table with a treadmill, a squat rack, and a jump box to truly understand, diagnose, and treat the female athlete's anatomy in motion?
It's a great question.
It is a fascinating question to ponder, and it highlights just how rapidly this field is evolving. Thank you so much for joining us on this deep dive. We hope you take these insights, keep exploring the mechanics of your own body, and apply them to your active lives.
Remember, if your internal bridge ever needs a little extra scaffolding, the tools are finally out there to keep you moving, dry, and confident.
Keep leaping, and we will catch you on the next one.